Thank you. I'd like to thank the moderators for inviting me here today. I think it's a wonderful opportunity for international collaboration. My background is in cardiovascular disease and health outcomes research, and I really appreciate the opportunity to visit my first time here in Portugal. I think I'll be taking a different perspective than my predecessor. I'm here to help, hopefully, as you're moving forward with your project, to think about some of the opportunities and some of the barriers, because one of the things that I've learned over the course of doing this work for the last 15 years is that if you identify issues earlier, you're more successful and you spend a lot less money and have far fewer headaches. So I'll be talking to you about the collaboration that I've been involved with for some time between Minneapolis, St. Paul, and Göteborg, Sweden. And I just wanted to give a little bit of perspective. One of the things that we'll be talking about today are the types of studies that can be done, and obviously we're all interested in the common goal of improving the quality of healthcare, and that's the perspective I took as a clinician, as an interventional cardiologist. And when I started the clinical practice, everything I did was based out of New England Journal and JAMA, and looking at clinical trials, which obviously is a way of looking at treatment effect or the efficacy. But I became very quickly interested in looking at the effectiveness of treatment, whether or not what we learn is actually used in clinical practice. We spend so much money on doing highly selected clinical trials, and it takes a very long time to disseminate information. And even after that information is disseminated, a very small proportion of patients actually receive treatments that we believe are highly efficacious. And so prospective cohort studies are obviously an ideal way of looking at this, and this can relate to anything from pharma to clinical care to devices. However, what we recognize is that over the course of time, prospective cohorts require several things. One is the opportunity to collaborate. Another is sometimes a long period of time. And third is a lot of money. And so one of the opportunities that I looked at early on was doing either cross-sectional surveys or doing retrospective surveys. And those have a very unique opportunity to look at real-life healthcare. And what I learned as I was moving forward is that a very small proportion of patients that I see in clinical practice are typically candidates to be enrolled in clinical trials. And I've learned that as I've participated as an investigator in numerous clinical trials over the years. And I've also looked at that when I've gone back and looked at the literature, and we've tried to match the patients that we see versus the proportion that go into studies. And that number is typically under 10%, probably closer to 4 to 5%. And obviously, one of the things I think that the CuteHeart project is looking at is the impact on care in Portugal. And obviously, there's no single standard. One of the things I'd like to emphasize here is that what some people perceive as superiority and inferiority is often heterogeneity in practice, and the two of them are not identical. So as I was looking back at this and putting this together, one of the things I wanted to get a perspective on is where did this all start out of? And this work that we're talking about here goes back many decades. And it's interesting that out of the state that I'm in now, but not my home state, Minnesota, was one of the original studies that looked at epidemiologic studies. And if you look at a lot of the original a lot of the studies that were done, particularly the 7-country study shown here, these studies were global studies, international studies. And when I looked at the paper by Wong that was just published earlier this year, one of the things that I was surprised to see is that as we've gone forward, these studies have become far less frequent. And this paper is not exhaustive, but what I looked at is I just broke this table into 2 sections here. It's very interesting that a lot of these studies follow the track of money and where this money can come from. And a lot of the more modern studies over the last 10 to 15 years, many of these are not based out of industry, obviously, but they're based out of NIH, and they require a large number of patients, anywhere between 5, 10, 15,000 patients. But it's very hard to do this type of work at an international level. And I actually believe because of the cost of healthcare that a lot of this work is becoming increasingly more difficult to perform. So what are the primary reasons to do international collaboration in epidemiology? And as I said, as I was putting this together, I found a very interesting paper here by Pierce. And there are many good ideas. And one is that most of our good ideas, particularly those that are hypothesis generating, have come from population comparisons. You do something one way, in my country I do it a different way. Why is there heterogeneity? What can we learn from that? And how can we move forward? The second is a lack of variation of exposure within the high-income countries. And these are what I call the sexy studies. You look and see what happens in a country which doesn't have resources. You look at a country that does, and this could be anything from nutrition to smoking cessation to just basic health care, and you see significant heterogeneity. The third is lack of generalizability between high-income and low-income countries. Fourth, lack of exposure in high-income countries. And fifth, the importance of addressing the most important public health problems on a global basis. And that's probably what the CuteHeart project in part is related to. So how do you find a good partner? And this is not something that I can claim to be responsible for. My mentor, Russell Lepker, was responsible for this along with Johan Hurlitz out in Sweden. And one of the things that they looked for is homogeneity in the population. And it turns out one of the things I learned when I moved from the East Coast to Minnesota is that Minnesota, that's a Scandinavian population. And it turns out that's not a bad place to look as Norway, Sweden, or Finland to find your matching group of patients. And the reason for that is that if you're looking to do a study and you have similarities in population, it's easier to adjust for factors that otherwise would be more difficult to do so. And also you share common aspects in culture. So in the Minnesota area, we have, in the 2000 population, over 2.6 million people. So even though a large state, most of our people are concentrated in the Minneapolis-St. Paul area. And I was particularly interested in looking at the elderly patients, mostly white and Northern European descent, but that actually has changed over the course of the last 10 years. And in Sweden, from the 2002 population, about 500,000, and ethnic Swedes represent the large majority of individuals. So these are the collaborators I've worked with, and I just want to give them credit. Russ Lepker, former president of the American Heart Association, and Johan Hurlitz, who has a CV which is probably thicker than the average textbook. Both of these individuals have been very good mentors for me and have been responsible for a large amount of cardiovascular epidemiology over the course of the years. I was also thinking about one of the things that you just mentioned, which is in the back, is how does industry get the knowledge of what we're doing? And it's ironic that Lindsay Smith, who I worked with, and I was her mentor at the University of Minnesota, she was just snatched up for the TVD project by Medtronic. So it's interesting, people move from academia into industry, and hopefully they take their knowledge and their methodologic approach there so the industry can learn from what we've created. So I'm going to talk to you a little bit about myocardial infarction and just give you somewhat of a perspective of some of the challenges that we've faced over the course of time. At a basic level, you have to understand not just the population, but really what is it that you're looking at. And when we talk about something as simple as a heart attack, something that I learned was based on symptoms and EKG and biomarkers, it turns out that something that simple changes over the course of time. We as clinicians think about a heart attack in one way, or I should say over the last 10 to 15 years now, it's not even biomarker based, with now everything being based on ST elevation. When a patient comes into the hospital, before you even get a rapid troponin test, somebody's looking at electrocardiogram and you're moving forward, and that's driving your healthcare process. But as an epidemiologist, as someone looking at the overall impact, you have to have some sort of baseline definition. And interestingly, out of Minnesota and the EKG codes, there was and is a standard for reading an electrocardiogram, so you can compare an EKG from 10 years ago to an electrocardiogram now. Obviously, technology changed over the course of time, and one of the things that we have to face is that as the biomarkers become increasingly sensitive and more specific, we sacrifice some things, we gain other things. And in particular, whereby we might have called something angina 5 to 10 years ago, those are now patients what we call small troponin leaks, small heart attacks, but they're now driven a direction differently in the healthcare system. So one of the questions we have to ask is, how does the evolution of an acute myocardial infarction, just simply based on the definition, impact on the prevalence and incidence of this disease? And how does evolution of technology, particularly more sensitive and specific cardiac biomarkers, impact on the prevalence and incidence? And the reason for that is that, I think Sharon, you would have far greater knowledge of this than I do, but when you go to the NIH and you come up with a great idea, one of the things that they're interested in is the impact and what you're really doing. So you may have a great idea, but if you can't show that you're going to have an impact on healthcare, on society, it's hard to sell that idea. And something as simple as a graph to the CDC, to the NIH, the American Heart Association, that shows a decline in the incidence reduction in the prevalence of cardiovascular disease is a very important thing. It means that hopefully all the work that we're doing really makes a difference in healthcare. And it's hard to sell something if the graph is going the opposite direction. If you're trying to sell something in diabetes where we're having a hard time making an association between glycemic control and any outcome whatsoever, and you're a new oral hypoglycemic, you're just a Me Too drug looking at a blood sugar. If on the other hand, you're looking at something like smoking cessation, where there has been a marked reduction, even blood pressure or cardiovascular events, it's an easier sell, I believe, and takes a lot fewer patients. So in terms of the international collaboration, one of the things that we wanted to do is identify countries with similar demographics, economics, but different processes of care to assess whether variation in practice impacts outcomes. And when I was out at dinner last night with my colleagues, that's one of the things I learned was a basic concept in the CuteHeart project. There's a sampling scheme, and we need to ensure that study samples are similar between the countries, ensure completion of the study samples, and ensure accuracy of the data collection. And I learned last night that that's some of the challenges with the ongoing project, and hopefully some information I can share with you. And then outcome assessment, something as simple as identifying endpoints of mutual interest, and then the importance of validating those outcomes. If you don't have a unique identifier for an individual, it's hard to determine, particularly with an administrative data set, whether you're the same patient's being looked at again, or whether or not you're talking about a new individual. And something that simple becomes something far more important in a small city, whether it be in Boston or Minneapolis, St. Paul, where you have 15 to 20 hospitals. And it turns out a large number of patients shift from one healthcare system to another. And the only reason I am particularly aware of this, and I don't think they have this yet in Boston, but it's coming, in Minnesota, we're adjacent to Wisconsin, and a nurse in the 1970s decided to develop an electronic healthcare record system, which is now Epic, and probably one of the largest electronic healthcare records, which will probably overtake the world in time. But interestingly, as of this past year, all of the major hospitals in the Twin Cities, including the peripheral hospitals, are on the single electronic health record. Even though each of them are maintained in its own individual hospital, we have the ability with a single click of a button and patient consent to access their records with the same defined data. So while I'm seeing a patient, if I have 10 patients, 12 patients in the morning, and I'm rounding, I'm sharing 3 rooms with my fellows, I can go and click a button and I can suddenly see their cardiac cath and their other data. And that becomes something very interesting as we're moving forward of how we're going to be able to collect data. We can now move, hopefully, from administrative data to a single set data definition. And as they're going through the next revision of this electronic healthcare record, there's now a greater emphasis on research. I'd like to think it's for the nature of helping healthcare. Obviously, there's an economic impact if everyone's driving the company to be able to collect this kind of data. And so I think that's particularly important. In terms of project development, one of the important things is face-to-face meetings. In this current day and era, a lot of things are handled by video conferences and teleconferences, but it's particularly important, I think, to have meetings like you're doing here, because you learn what your colleagues are doing, you learn their relative strengths, and I think one of the things that's been very important for us is you essentially get smaller groups working on particular projects, and when you have different groups working on different activities, everyone's moving the same direction, you have a common goal. You also want to have a shared effort in regard to methodology and statistical analyses, and I think that this is particularly interesting. I learned this when I was working on the cardiovascular cooperative project. It turns out you can take the same data set and publish 2 totally different papers because you're not looking at the data the same. It doesn't mean that one's right or one's wrong, although the more senior author typically generates the final paper. It turns out that there's different methodologic approaches, and oftentimes there are some errors or some issues with one or both of them, and the common concept is somewhere it lies in the middle. Also, it's important from the standpoint of publications. So discuss authorship at an early stage. You're going to be working between 2 major cities in Portugal, and you're going to find that you're going to amass a large amount of data. And also at an international level, working with the Harvard healthcare system, they're also going to have a large amount of data. Each of you are going to have different projects. There's usually, with a project like this, 2 or 3 major themes or major concepts that come forward where you're equally going to collaborate. But defining that initially, I think, avoids headaches later on. And then the scope of the project spawns many ideas and opportunities later. So the time frame, the Minnesota Heart Survey now dates back several decades. And when it started, it was every 5 years in terms of sampling. And we've tried to continue that over the course of time. There are other studies in the country that have done this. My colleague Rob Goldberg at the Worcester Heart Attack Study has also done similar work, actually in closer frequency. The study population is important to define up front, and I think that you probably are working on this area now. I think with administrative data, one of the advantages is you get an idea by looking at what you've got, how you're going to define it. In terms of the study population from Minnesota, we were able to generate a computerized list of acute myocardial infarction from each hospital. And ours is based on ICD-9 code 410, which is a heart attack, and ICD-9 411, which is unstable angina. But it's important, one of the things that we learned is that there's some number of unstable anginas that end up being heart attack and they're miscoded, misclassified. It's far less frequent now. And we have the same thing where we have people that are classified as heart attack when they went in and looked at, then they may have been Takotsubo disease, it could have been many other things, it could have been pulmonary embolism. But somebody who looked at this and coded it is not the research scientist. And the sad fact is that coding is not often based on the patient, it's based on reimbursement. So somebody is going to code a chart typically if the patient had presenting symptoms and it's the highest level of coding reimbursement, although it may not be the patient's major problem. In addition to this, we additionally sampled some of the unstable angina, as I said, and the samples range from 50 to 100%. Oftentimes this is based on finance and the number of hospitals participating, but we want to make sure that we have an adequate sample to be able to prove the hypothesis. In Sweden, I have to give credit to Johan Hurlitz, who with his small group goes out and grabs all of the data. Sweden's somewhat of a different country. It's one of the European countries where people are not, I would say, as safeguarded over the healthcare data. Although there are issues regarding privacy, everyone's part of a healthcare system, and therefore they don't have to fight the challenges that we have to fight often in the United States. It's important for us to make sure that repeat hospitalizations are not included. Obviously, there are reasons why you might want to have this, but if you're looking at the epidemiologic principles of incidence of heart attack, we'd want to avoid that. Excuse me. In terms of the definition of acute myocardial infarction, we defined it based on symptoms, ECG indicative of acute myocardial infarction, but ultimately it was based on a positive cardiac biomarker. And it was interesting because when I was working on this with the 2000 data set, Fred Apple, who's one of my colleagues at Hennepin, was doing a lot of the work with industry on the troponin. And at that time, troponin outside of the Twin Cities was not a big thing. And yet in the Twin Cities, when I first came there, everyone was looking at troponin. All the research over the next 5 to 10 years was still CKMB, and in many places it still is, and yet we weren't even using it. And it turned out by 2005 in our laboratory, we weren't even able to get CKMBs anymore. So it shows you the effect of technology as you're looking at something, particularly if you're doing a prospective cohort. What you started with may not be what you're using later, but there's a very important reason to start with the baseline. And I think Fred made a very good point of this when you talked about the propensity score modeling. You have to have a baseline. If you change your baseline, it's not going to be very difficult to validate against your original sample. So we talked about the impact of technologic advancement, also cardiac biomarkers changing, and that the technology impacts case definitions and hence the incidence of disease. So the hospital facilities in the Twin Cities, and this is a changing number as hospitals keep gobbling up one another in the United States of America, but we have in the low 20s number of hospitals that participate in the survey, and we're very proud that almost every hospital, with the exception of one small rural hospital, volunteered to provide us this data. And all the participating hospitals in the Twin Cities had intensive care units for AMI treatment. Cardiologists provide the vast majority of care to these patients. Depends on where you go in the country. In many places, particularly in rural hospitals, that may be handled by a hospitalist or an internist with a cardiologist consulting. Cardiac catheterization and PCI was available at over half of the hospitals, and these accounted for 3/4 of all the primary AMI admissions, meaning the person was admitted for that reason. In Göteborg, Sweden, there were essentially 2 large acute care hospitals, each of which shared approximately 50% of the patients. Most patients were admitted to a CCU and received treatment from fully trained cardiologists in training, or internists who required cardiovascular training to take care of these patients. And cardiac cath and PCI were performed at both hospitals, although one only performed 24/7, but could take hospitals at any time. So I put this slide in last night after talking to you about some of the issues regarding administrative data, and Fred mentioned some of this, so I won't go into this into depth, but there's advantages and disadvantages with each of these. If you're starting up a project, administrative data has a nice opportunity because you can standardize your data, and you have data that's more readily available, and it costs far less money to collect that information. And in many situations, that data was being collected for a different purpose altogether, and therefore, if you're someone like Sharon who knows to tap into anything, you know how to get access to data. And data is key. Some of the problems that we've thought with administrative data, and I learned when I worked on the cardiovascular cooperative project over 15 years ago, is that both the scope and the depth of the data is limited. And it turns out when you go back to the medical records, what you think is often not the case. And so the question is how much resources you have, and that's not just cost, but it's also time. And one of the things that I learned is educated abstractors, the persons that are actually going to be doing the work at the ground level. So one of my colleagues designed the database system here over 20 years ago that collects this data. And I just want to talk to you about what we did. We did this for heart attack. We've also done it for heart failure. But we have trained nurses that are supervised by physicians, and inter-observer variability was assessed by random reabstraction of these charts. And we collect a large amount of data. One of the things that I learned coming out as a cardiology fellow is that there's never too much, and I made the error of going out and going deeper into charts. And when you start trying to abstract cardiac catheterization records or PCI records, one of the challenges you face is that how do you design the system? So the data abstraction that we did was about 1,500 data elements, which is not a small amount of information. And the abstraction process took anywhere between an hour and a half to 2 hours, and this was all a funded project. But we did get a very rich amount of data on these patients, including their demographics, their history, symptom signs, the basic stuff, laboratory ECGs, and particularly procedures and pharmacotherapy. And to some degree, you can collect some of this information with administrative data, but when you look at the patients and what was actually done, you learn that there's a large amount of variability. This was done on laptop computers, and one of the things you have to determine is when you're doing this work here and at Harvard, who's going to be collecting the data and how's that information going to be harvested from the system, and how are you going to synchronize the systems?
What about outcomes?
The outcomes data? I'll talk to you about that in just a moment. So in terms of the outcomes data, hospital-based information we collected at the time of abstraction. In terms of subsequent information, particularly mortality data, we had that through Mindex. I've just, in the last several years, designed an algorithm that we're validating in Minnesota to try to see how do you know that a person's dead. So it turns out when you have millions of people, there are a lot of people that have the name of Smith or whatever the name may be. And so the algorithm that I've developed is based, it actually uses SoundX definition. We use statistical software, SAS, which allows you to have a lot of advanced modular component programming. And so we can look at not just the basics, including name, date of birth, address, but we can also do SoundX and digit transposition. And using that, I've been able to match these in over 99.75% of patients. It's not 100, but it's a lot better than what we were doing in the past. And one of the things that we did when I started looking at this is it turns out that people that others had not identified as dead, I did. And it turns out there's a reason why you don't want to die. And I learned time on, it's Medicare beneficiaries receive money from the government. And so husbands and spouses share Social Security numbers, and it turns out oftentimes people don't report that information. It takes a while to get into the system. So I actually think that even though it was 97.5, I may be the source and not the validation for some of these individuals. One of the other things that we did, and I'd be interested in hearing how you're doing this, is that some information is very hard to collect in a discrete way where you want to have that information for alternative purposes. Something as simple as the electrocardiograms or the coronary angiogram reports, we collected that and Xeroxed that information from those medical records because there may be a time later on when you want to go back, particularly if somebody working on the CuteHeart project says, this is fascinating, look how many more angioplasties you did the coronary angiograms. It may not be, once again, that somebody did a better job than a different job. It may be that what you were seeing was different than what you thought you were going to be seeing. And meaning that could be the nature of the disease or how you interpret the disease or whether or not the patients came back and had a repeat procedure. There's also a detailed manual of operations, and I give a lot of credit to the people working behind the scenes. So you have a paper abstraction, and I took this for granted when we were doing this project. It's probably one of the things that you're going to be facing now is when you're looking at administrative data is how do you interpret that data? Something as simple as, there's very few things that are yes or no. Even death turns out to be highly variable when you're not sure whether or not the individual may have died. But you have to tell the people who are doing the data harvesting how to handle something. Is this hypertension? just because they said it's hypertension, or is a blood pressure of 180? Was it on the time of arrival? Could have been during the first 24 hours. Is something as simple as an aspirin administration count? What if the EMS gave it to them before they got into the hospital? It turns out that in certain cities you may have a utilization rate in the hospital or in the emergency room of 80%, but that's because the EMS systems in those cities are administering aspirin in the ambulance. The documentation may show it, but it's not reflected in the electronic medical record. Your hospital looks bad when you actually have 100% compliance. So this all gets down to how you're handling the data. So the content, make sure all the variables are well defined, how you're going to abstract that variable, and what to do with a lot of what-if situations, and that's what I did. In terms of vital status, we obtained that from the medical records. After hospital discharge, vital status was obtained, and after hospital discharge from the computer linkage with death certificates provided by the Minnesota Department of Health and the Swedish National Registry. And we have a complete set of death records in the Minnesota Department of Health, and in Sweden, survival confirmation, as well as the date of death who died was obtained from the population registry. It's become a little bit more difficult to get this information in the United States. If you have a good connection with the Department of Vital Statistics, that information now is really much more closely guarded. It's interesting, but in the 1990s, you could walk around with on your laptop computer, you know, files that were gigabytes of size that had everybody's name and et cetera. And with HIPAA and state changes in statutes, I think a lot of this is also being seen in Europe and Australia, as I understand, New Zealand. Things have gotten a lot more tight in terms of this. So current opportunities, I want to talk about the recognition of the importance of identifying trends. I think it's critically important to identify the incidence of acute myocardial infarction. It's not just what you're doing for it, but whether or not you're making an impact. And trends in treatment, including pharmacotherapies, diagnostic interventional procedures, as well as case fatality. I think that this is the basic information, Sharon, that you're going to get in this data collection. And although that may be a small component, it's a very rich point to start, because if you can tell your country, this is what we're doing, and this is what's happening in 2 or 3 years, it's particularly important. And it's interesting, it's, you know, research and the whole idea of translational research is what you learn in the lab, is what you take into clinical practice. And in the early 2000s, as I was putting the points onto a line and publishing data with regard to the trends in MI, and other people were just saying this is just kind of a statistical fluke, I said, this is not. We are really having an impact here. Subsequent papers in JAMA have talked about 50% of this being a reduction in the modification of risk factors, 50% in terms of treatment, in terms of why there's a decline in cardiovascular disease in our country, but it is real. And I will tell you that it impacts at multiple levels. I talked to my colleagues who were talking about growing cardiovascular practices. Fred, you're dealing with this. Everyone wants to make their programs bigger. And in point of fact, you have to face the fact that if your program is getting bigger and the disease is shifting in the opposite direction, you either have to change the nature of who you're going to focus on. Maybe it's valvular disease, maybe it's new programs, but you can't just keep ballooning vessels and expecting that those patients are going to come to your healthcare system. And so some of the work that we did, I think, was really critical in identifying that. And it's also very important to CMS, to essentially the people paying the bills. In terms of data collection, that's where I think the future opportunity is, and this is one of the things that hopefully I'll be able to work with you on down the line now, especially with EPIC and what we're doing. I believe, especially if we go in for this again with the NIH, that we are going to go in with the EHR and we're going to have one step better than the administrative data, is that we will have the advantage of an administrative data, meaning immediately accessible data in an electronic feed. And no one has this yet. So my colleague is working on resuscitation science, and I spoke with you last night about this, but the idea of having immediately available data, but data that's actually reasonably accurate, is particularly important. Otherwise, you're facing anywhere between 2 and 3 years of being able to catch up with information that quickly becomes arcane. The Health Insurance Portability and Accountability Act, which every time I think I understand, I truly don't. Essentially, this is now the system of security for the healthcare system in the United States and now going on around the world. But it puts a lot of constraints on the records, and patients have the right to opt out now. And so we have a new system in place at the University of Minnesota so that we have access to these records, and the entire healthcare system is now partnered with the university with legal contracts that allows us to take information, de-identify that information, and essentially within minutes we can query a system and get immediate access to millions of healthcare records, and that's particularly useful. Also, for large observational studies being costly, the resources of data abstraction become an increasing barrier over the course of time. So I want to spend the last few minutes just talking a little bit about some of the data, and I took one old study and one of our more recent studies to give you an idea, because I think that this may be the direction of where you may be going with your project, the CuteHeart study. So the first thing that you do when you look at this is you try to get an idea of what's the incidence of your disease in terms of how you're looking in terms of both CHD mortality as well as hospital AMI in men and women. So at basic level, you're going to have the following information. You're going to need to know by gender in your 2 countries how many people have the disease and who's dying. That's the first question you're going to answer when you collect this data. And you will be able to get this. And the age-adjusted CHD mortality was lower for both men and women in Minneapolis and Gothenburg. And the age-adjusted hospitalized AMI discharge rate was higher for men and women in Gothenburg than Minneapolis. So as soon as you see a discrepancy without having any ability for adjustment, you already have the nidus for research. And I think that that's where you start. We saw early on a very big difference here. And I would say that once again, and we've struggled with this over the course of time, is greater utilization of procedures or pharmacotherapy a surrogate of better care or just different care? And it's interesting, and I'll show you some of the results, and particularly with beta blockers, where some of the original data came out of Sweden with the acute myocardial infarction. They were the first ones to discover this information. But it became evident very early that in the United States, particularly in the Twin Cities, we were very, some people might use the word aggressive in terms of our approach. Some people use the word less conservative with our approach. But a large proportion of our patients end up in the cardiac catheterization laboratory. Now, interestingly, the converse of that would be whether or not they had treadmill studies. So you can see the opposites here. And we talk about statistical significance. I like to think that statistics, they're important, but they should be driven not by stochastic significance, but by clinical significance. To see a difference of 2 or 3%, even if the p-value is less than 10 to the negative fifth, is not important as seeing a 3-fold difference in cardiac cath rate. So even if that value had been a p of 0.07, I'm trying to figure out why are 3 times the number of patients not stochastically significant going to a cath lab. Are we just crazy, or are we doing something different? And so I'll show you a little bit of that. So early studies showed a marked difference in the use of both diagnostic procedures and coronary vascular procedures with rates higher in Minneapolis than Gothenburg. And we also saw differences in pharmacotherapy. Early data showed a difference in the use of what are now considered standardized AMI pharmacotherapies. And I believe that you'll have access to this information, although I'm understanding not necessarily with your inpatient. My hope would be that as you look at your data, you'll find ways of being able to harvest this from that, or in the second iteration of your data collection, that you might be able to get certain therapies that are going to be particularly important. Because there is a lot of data that shows, particularly for things like aspirin, statins, beta blockers, and ACE inhibitors, that compliance with these therapies does impact on outcomes, both short and long term. Yeah. And indeed, we found a difference between Minneapolis and Gothenburg in terms of outcomes between these, with survivals less, and obviously this doesn't go down to 0%, but there was a difference between these, most evident in men than women. So the final study I'll show you here was with regards to the data that we published a year ago in the European Heart Journal, and it turns out that these differences still persist. We're seeing a difference even as recently as the last several years, and this impact on survival, aspirin, ACE, nitrates, and additional antiplatelet agents between the 2 areas. We also saw that the coronary angiographic rates, as well as PCI, and that includes not just primary PCI, but particularly all patients undergoing coronary vascularization rates, still higher in the United States than it was in Sweden. And interestingly, a difference in ST elevation MIs, which I have not been able to explain. Finally, as I just show you some of the differences in the pharmacotherapy, and this is one of the final slides here, there is a difference even now, although it is relatively small, between the survival rates between these countries. So I think that there is room for improvement. I think that we need to be able to figure out the differences in terms of what we're doing in terms of pharmacotherapy, in terms of procedures, and hopefully some of these opportunities, particularly with regard to the methodology and the data collection, will help as you move forward with your project. Thank you very much.
I don't think I was the best chair. The 2 talks were so interesting. I didn't hold you to the time, but I really enjoyed it. I'm going to just make a comment and open it up for questions. Just wanted to indicate to you that we're finding the same results with the U.S. and Portugal in terms of the STEMIs being more prevalent that we're seeing in Portugal relative to the U.S. And of course, the higher utilization rate of the procedures in the U.S. So it's reassuring because we don't have the detailed data that you have, but we seem to be seeing a similar type of story. So I wanted to open up this particular talk to any questions.
Sure.
Thank you, Dr. Berger. Very interesting. Now, you mentioned on your first or second slide that you're going to look at variation in practice.
Look at variation.
That you're going to look into variation in practice. Did I got it right? One of the studies was to look into variation in practice.
Yes.
All right, so when you look at the final slides, what you see as a major difference is the percentage of interventional cardiology between the American patients as compared with Swedish. So you're suggesting that that's the main variation that could explain different results?
There were also differences in pharmacotherapy as well. So, I mean, it's interesting. Even with the level of detailed data, one of the things that we've always presented, we've been very cautious about, and when I spoke with Russ Lepker the other day, one of the points that he wanted me to bring out here is that you've never explained everything. And so there could be differences. For example, one of the things that is particularly interesting is whether or not time to therapy. You know, we know this for a fact that when you're in a rural area or you're covering a larger area, it takes a longer period of time for patients to be able to hit a cath lab, for example, or to get treatment. And one of the biggest factors, other than age of a patient, extent of disease, is time to treatment. So some of the risk adjustment will never be totally explained by what we're seeing. But I think that you're right. I mean, there's something that, yes, you know what? I think that you're right. And so, right. If it was a 5 or 10% difference, but these, and even though the gaps are closing, they're still not there yet. And I've visited Sweden now on more than one occasion. There is a difference in practice. And so I'm not saying that one is right or one is wrong, but there's probably, the way I would say is that there's lessons that can be learned from both sides. They're much better in terms of pharmacologic compliance with certain agents than we are. It took us everything that really came down to CMS compliance and being graded as a hospital to get our numbers uniformly across the country above 90, 93%.
I find this very, very interesting because we've been working with the data for such a long time and now seeing that we have the same results. At the beginning, we thought, oh, maybe there is something wrong with either the US data or the Portugal data, but then we see the same and, you know, it at least makes us more confident with that. One other thing that I noticed you said at the beginning is that it's very important to have an ID for each patient, and this is something we actually struggle because the data we have been using for the US, we don't have an ID for the person, we have only a discharge. So it's sometimes you wonder if it's that could, you know, cause some of the differences because maybe, you know, you count the same person twice because it looks like a different, you know, it is different.
That may be able to be overcome because we initially dealt with the same issue. So I understand that you have the administrative data set, but one of the things that we did to overcome that, and I bet you could do that there, is you go back to the hospitals and you match the cases against the hospital's unique identifier numbers. What we did is you essentially have a second key. And that second key is not shared among the hospitals. And what that allows you to do is cross-link the hospitalizations, and then you remove that after you link the hospitalizations. Now, I understand with administrative data that there are limitations. It depends on where you're getting it from. But I think that Massachusetts, like Minnesota, you know, we have, you know, an organization that is tracking these and then turning this information in.
Yeah,
so you're doing the whole country, right?
Yeah, we're using the so.
Okay, too large.
I think the problem is that we actually wanted to use the Massachusetts because in Massachusetts we have the same person, so we can look, we can actually build episode and everything, but we cannot do for the national sample that we have. The other thing that I want to ask, maybe I'm not sure I understand, the pharmacology is outpatient or is what happens in the hospital?
It's hospital-based. So it's inpatient, but we have both inpatient and discharge. But the discharge is coming from the hospital record, the prescription of the medications at that time.
Okay, because that would be for us very important to get and.
Right.
Yeah.
Right. I think that's.
But for Portugal.
I think it may be interesting to go back. I don't know. You know, this goes into, you know, everyone's always impressed by large numbers, 250,000 heart attacks, but you may be richer with a cleaner set of data when you go back to Massachusetts, and that would be my suggestion is. You know, start with everything, but then take the set of data that you can link internally. It may require some separate funding, but it actually does, it turns out that it's not that expensive. It's just access to the information.
Yes, at the beginning of your talk you mentioned several historical studies. I've been working in this field for many, many years, so I follow them, and of course, 7-country studies, Nihon San, Monica, Ansel Keys, Henry Blackburn, and all this. But what was the main message of this part of your presentation?
So when you're saying what, so the perspective I was trying to give is I was thinking about the development of what you guys are doing here is the idea of how does collaboration across the countries make a difference, and where do we go from here? Because a lot in the United States, you can't do a project unless you can fund the project. And one of the things that we've seen is you have to have more and more clever ideas, but there's been a move away from international collaboration, and I think that that's kind of unfortunate because some of the greatest opportunities are where you see the greatest differences. And I think that, you know, although, fine, it may be interesting in the United States that, you know, I'm doing something at the 7%, you're doing something at the 9%, and now I can make it 7.5. I think the difference between a 20% and a 40% where the difference may be life-saving has a much greater difference. And I think that we see this not just in cardiovascular medicine, but I think particularly where this is very interesting is completely outside of cardiology with issues like vaccination and infectious disease where there's just such an incredible discrepancy, and by addressing some of that, you save lives.
Completely agree with you. I think, for instance, the 7-country studies have a tremendous impact. And again, Sweden was represented there, I guess. One cohort also.
I think we'll have a final question because I know I need coffee and I don't know about anybody else, but...
Thank you. One last question then. First, I would like to ask you about, we saw some interesting results that were unexpected, and we are very reassured we are getting the same kind of results here when we compare Portugal with the US. But have you considered the possibility of some of the data being the methods of obtaining the data, the different methods in the US and the Sweden as an explanation for some of the weird results that you were getting? So you have a larger incidence but lower mortality, you have more intervention and less surgery. So there are some conflicting results. Have you considered the hypothesis of being data related or data collection methods related? We are thinking about that here in Portugal, and we are not really sure of what is data related and what is a real phenomenon. And lastly, because of these, we have, for example, compared some of the large data sets that we have with some specific interventional cardiology registries, and we are actually having within Portugal some strange differences between registries and what we see with administrative data nationwide. So probably these differences within the Portuguese data registries, again administrative data, are related with some kind of selection bias in the registries and not so much in the nationwide data. But I would like to see what is your opinion about this problem of what is data collection driven, what is real phenomena, and how can we confirm or...
Okay, so recognizing the amount of time, it's a pretty big question. I'll answer the first one by saying this. With the majority of people here, and particularly from my clockwise and 90-degree arc being statisticians, I won't challenge the statistics. What I will say is I learned some very basic principles while I was at Hopkins. And one is that when you have 100% collection and your sample is your population, you're good to go. So at least on the Swedish side, I don't believe that that's the case. And in the Twin Cities, I believe that we were also pretty solid on this. In fact, with women for the 1990 sample, we did 100% because we were very interested, I was interested in the elderly population, particularly in women. So having said that, I think that the abstraction process was very detailed. Do you collect everything? No. I mean, it's a continuum. But I think that it becomes asymptotic in terms of the time spent versus the acquisition of greater knowledge. And I think that we've pretty much plateaued at that level. So I think that we did a pretty good job on that. Obviously, I'm biased because I was part of the study, but I came into this 20 years into this. So it had gone through multiple iterations. And for the CuteHeart project, this is step one for you. I do think, though, that one of the challenges that you're going to be dealing with, and I think that at the regional scale, you compare your registries versus what you're getting in your project. In the United States, it's what you're getting in Massachusetts, which really, I'm not saying it's too much bias, but I was there. It's a high standard. If you look at heterogeneity care, and this was looked at Tufts in particular, when they did their geographic mapping, healthcare in Minnesota, and it's Massachusetts and Minnesota, a lot of the M states, it turns out, is different than what it is in a lot of other parts of the country. One of the reasons for that is that it's less of a rural population per se, and a lot of the academic medical centers in there, and there's incredible intense pressure on these institutions to perform at the highest caliber. I really believe that drives a lot of the healthcare quality. And you may not see that elsewhere. So you may find in one of the papers that you may look at is really variability in care, not just between the countries, but what I would look at is between the metropolitan areas and the rural areas in both countries. You may find out that, for example, in the middle of Colorado, maybe not in Vail or Aspen, but in places where there is no cardiologist, that care may be the same as a rural community in Portugal where the person's not getting, a cardiac cath. And so I think that would be something very interesting to look at.